Today, we are starting the CME for the month of the Neurosciences Forum along with IMA. The Secretary of the IMA Pollachi.
Hello, sir. Good evening. This is Dr. Raghuram, Secretary of
Yes,
IMA
sir.
Pollachi.
Yes, sir.
So, shall I start with the IMA prayer, sir?
Yes, sir. You can
Sir,
start.
Jnanasundar sir is available, sir. So let him come with the IMA prayer and you can give a Christian prayer, sir.
Okay, sir. Let him do it.
Sir, Jnanasundar sir?
He told he is in an emergency.
Oh, fine, sir. Then
Told
you
he
can
will not
proceed,
be. He will
sir.
not be able to join the
Oh,
Sonaran, sir.
okay, sir. Fine, sir. Then we can start, sir. Yes, sir. Yes.
Okay, IMA prayer. May everybody be happy. May everybody is healthy. Be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. So, shall we proceed with the physician prayer also?
Yes, sir. Yes, sir.
Okay. Dear Lord, thou great physician, I kneel before thee, since every good and perfect gift must come from thee. I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Taken from my heart all guilt and worldliness, that with the simple faith of a child I rely on thee. Thank you, sir. I think we can proceed with the welcome address, sir.
Yes, sir.
Senthil, sir.
Senthil, sir.
Yes, sir. Yes. So I welcome all our faculties and course directors and our branch IMA Pollachi branch members and also IMA TNSB members to the wonderful CME session. So this is our first CME from AMS wing of Pollachi branch, IMA branch, and hereafter we are planning a series of CME programs with the Neurosciences Forum, and this will be having our credit hours also. So this time we are going without credit hours. From next time we'll be availing credit hours also. So I request all our members to utilize this wonderful opportunity, and our course directors, Dr. Rajesh Babu sir and Dr. Vikram sir, have planned a lot of programs. So let us all join for this program. And I welcome all the speakers, two star speakers of the day, Dr. Vedhanayagam sir and Dr.K. Selvamuthukumaran sir, for this wonderful evening. I welcome you one and all. Thank you, sir.
So, good evening, everyone. We are continuously doing this neurosciences program. And in each of the programs, we are having the two people, one neurophysician and one neurosurgeon, and the relevant topics in which their specialty, they are very much well versed. So today we are going to have the two nice speakers, Dr. Vedhanayagam and Dr. Selvamuthukumaran sir. In this neurosciences forum, lot of neurosurgery PGs are invited, and also the lot of the neuro doctors, neurosurgeons and neurophysicians are also invited. So I like to tell that all of you to become first of all the IMA member. Those who are not become the IMA member, please become IMA member. And the neuro doctors, those who are not the members of the Tamil Nadu Association of Neurological Surgeons, TANS, please become the member of TANS. And those who are not the members of the Neurological Society of India, the neurophysicians and neurosurgeons, please become the member of Neurological Society of India. This is the neurosciences forum. That is the main thing. And also for the neurosurgeons, please become the member of Neurodrama Society of India. To become the member of in any of these societies, if you have any difficulty, you please contact me. My number and everything is there in the invitation and everything. So I invite all of you to be the part of our neuro forums and to take part actively. I request all the participants to be actively attending the program, because at the end of each session, we will be having the question answer session. You have to give the answers online in the chat box itself, so that those who are answering first will be given the awards. And we will be having a neuro physician question separately and neurosurgeons question separately. So all the questions will be done only at the end of both the talks. So I request all of you to be attentive and be answering to all the forums. So now we will have the first speaker of the day, Naveen, Dr. Vedhanayagam. He is a senior consultant neurologist, neurophysician at Sri Ramakrishna Hospital, Coimbatore. And he has done his DNB, General Medicine and DNB Neurology, and experience of 10 years. Dr. Vedhanayagam's educational journey is marked by significant milestones. He started his medical career as a medical duty officer in 2008, eventually advancing to graduate as a general physician in 2011. During the time, he gained extensive experience in critical care, particularly in the medical intensive care unit and pediatric intensive care unit, centering his skills in managing complex cases. Dr. Vedhanayagam went further with his specialization by obtaining DNB in general medicine, followed by DNB in neurology. His pursuit of excellence led him to Apollo Main Hospital in Chennai, where he acquired his super specialty degree in neurology, solidifying his expertise in this field. Under the mentorship of Dr. Ashokan, he served as an assistant neurologist before assuming the role of consultant neurologist at Sri Ramakrishna Hospital, where he continues to contribute his experience to the patient's care. His expertise, neurocritical care and stroke unit, honor and awards, multiple national and international paper presentations, third prize winner at National Shine Neurology 2016. So I welcome Dr. Vedhanayagam sir to give your lecture on a clinical and practical approach to vertigo. Welcome you, Vedhanayagam sir.
Thank you, sir. Thank you, sir. Today's our topic is on vertigo. Now you can see that Gail is walking on the rope. You can see she stabilizes her eyes and she stabilizes her necks and trunk, and he also holds the stick on her hands, and she also walks on the ropes without any fall, without any agitation. So how does it happen? It is because of our central and peripheral vestibular system. So that system we are going to see today. So we are also having this same basic balancing system. Now we are going to examine and going to approach the patients with the vertigo. So these scales will tell us about the functions of the vestibular system. Yes, the function of the vestibular system is to stabilize the gaze and balance the locomotion and the body position in regarding to the gravity, and also adjust the autonomic functions. That means that readjust autonomic functions. When the head drops down, the BP should not go up. When you stand up, the BP will go down. So readjust autonomic functions once the body is oriented. So next slides. This is the systematic representation of the peripheral and central vestibular system. So you can see. Hello, sir. Is there any problem in audio?
No issues, sir. No issues, sir.
Yes, I can count that, sir. Yes. So this is a schematic representation of the peripheral and central vestibular system. you can see that on the otolithic organs like utricle and saccule, semicircular canals, and vestibular nerve. These three are called as peripheral vestibular system. And beyond the nuclei, that is beyond the vestibular nuclei, this is called central vestibular system. That the vestibular nuclei in turn connected to the cerebellum, oculomotor nuclei, and spinal motor neurons through the efferent pathways. These are central vestibular systems. So now we are going to see about the functions of these vestibular efferents and functions of these nuclei and functions of these peripheral and central vestibular system together. The slide sharing is not visible to me.
The slide is visible for us. It is visible for us.
Is it visible to you?
Sir, it is visible for us, sir. Yes, sir.
But for me, it is how changed. In the laptop, it is not coming. But in the different phone, it's coming.
Okay. I will open, sir. One second, sir.
No problem. I will go with this.
Sir, நீங்க திரும்ப ரீஷேர் பண்ணுங்க சார்.
Resharing.
சார், நீங்க திரும்ப ஸ்டாப் ஷேரிங் மட்டும் ரீஷேர் பண்ணுங்க சார்.
So this vestibular nuclei in turn connected to the vestibulocerebellum, extraocular movements, thalamus, reticular formation, and opposite of the vestibular nuclei. So same side vestibular nuclei also connected with each other. So the main function of the vestibular nuclei is to connect it to the all these centers. So first function will be the vestibulo-ocular reflexes. That means the vestibular nuclei connected to the 3, 4, 6th cranial nerve through the medial longitudinal fasciculus. That's why it stabilizes the gaze while moving our head and body. That's why our reflexes are pertaining and there is no nystagmus during our movement and ocular fixation. So that means if you have a problem in the vestibulo-ocular system, you will have a nystagmus. Or otherwise, in the same thing, the vestibular nuclei connected to the spinal cord through the lateral vestibulospinal, medial vestibulospinal tract, where it maintains the body posture, head and neck posture, and extensor balance. And the vestibular nuclei connected to the cerebellum through the vestibulocerebellar fibers. It helps to coordinate and maintain the body balance. And also it connected to the autonomic nervous system. That's why it's maintaining the balance system. And if you have any problem in the autonomic nervous system, then you will have a sweating, pallor, and palpitation followed by nausea and vomiting. These are the symptoms of Meniere's disease. Yes, because we are having a problem in the vestibular system, as it connected to the autonomic system, we are having this nausea and vomiting. And the vestibular nuclei connected to the opposite also. So usually there is no cerebral cortex pertaining to the vestibular center. But however, we have some posterior temporal lobe and posterior parietal location has been loculated and documented as a vestibular center in the cortex. So, or otherwise called as vestibular cortex in the posterior parietal areas. So in short, so brainstem has a vestibular nuclei. It is connected to the thalamus and cortex to maintain the spatial orientation. It connected to the oculomotor nuclei to steady the eye movements, and connected to the spinal cord to maintain the posture and muscle tone of the body, and it connected to the cerebellum to maintain the coordination of the eyeball and body movements. So let us go to the peripheral vestibular system. The peripheral vestibular systems are simple. The semicircular canals, utricle and cycles followed by the vestibular nerves. So now you can see that in the picture, you can see the semicircular canals. The superior, lateral or horizontal are the same. Superior and anterior are the same. And the posterior semicircular canal. These are the 3 semicircular canals. The 3 semicircular canals ends in the ambula. The ambula contains the cristae ambularis. That means in the cristae ambularis acts like a swing door. So either you can go in or go out. Like that, you can move inside and outside of the door. So that's why if your fluid moves one side, the hair cell will be stimulated and the firing at the nerve terminal will be happening in the semicircular canals. Whereas in the utricle and saccule, they have a special cells called macula. In the macula, there are two types of cells are there. The one cell is flask shape and single nerve terminal. The type 2 cell is cylindrical shape. It is multiple nerve terminals. So that much integration in the nervous system helps in balancing our system. So in the utricle and the saccule, this utricle and saccule have the macula at the posterior wall of the labyrinth. So that will help in movements of the body in relation to the gravitational movements. That means the translational movements, either forward, backward movements and lateral movement. These are detected by the macula and saccule, whereas the rotational movements are detected by the semicircular canals. So you can see the picture. This anterior or superior semicircular canals moves, fluid will move when you say yes and yes, like this. So in the posterior canal fluid will move when you head tilt towards your shoulder. In the same way, if you say no and no, that time the fluid in the horizontal canal will move flow to and fro. So these are body fluid and the body movements in accordance to the fluid movements in the plane. Another more important point in vestibular system is the both anterior and posterior semicircular canal on the same ear is situated right angle to each other. Like that, left anterior and left posterior canals are right angle to each other. However, the left anterior and the opposite right posterior canals are in the same plane. So that means the orientation of the plan, LARP, LARP, that means left anterior and right posterior are in same plane. That means the body movements will be easily detected by these arrangements made given by the God. So it is a better arrangement given by the God to perceive our body movements. The next things, there are three types of rotational, three types of translational movements are possible in our body, and mainly in the head and neck portions. So three rotational movements are the roll, pitch, and yaw. Three translational movements we know that right and left, up and down, and front and back movements. So I already told that superior semicircular canals usually measures the rotational movements, whereas the utricle and saccules detects the mainly translational movements. For example, in this picture, you can see that head turns to the right side. What will happen? The fluid in the horizontal canal will move to the ambula where it fires the ciliary cells, and cilia will get activated and the firing of the right vestibular nerve will be activated. However, there is a depolarization. In the opposite side, the fluid moves away from the ambula. That's why it is hyperpolarization, and there is a decrease in firing on the opposite side. That indicates the balance between the right and left horizontal canals makes the head movements possible to realize to the other systems. So now we can able to understand. Thus, in the nystagmus, in the horizontal canal will be horizontal nystagmus. In the pathology in the vertical canal, pathology in the posterior canal will produces vertical nystagmus, and the pathology in the superior canal will produces a rotating nystagmus. By simple, if the anterior semicircular canal on the right side is stimulated, the right superior rectus and the opposite inferior oblique will be contracted in order to maintain the posture. Whereas opposite, that means the left ipsilateral, that left inferior rectus and the contralateral superior oblique will be relaxed in order to maintain the posture and gaze. So these are simple but complex arrangements of the vestibular systems to maintain the balance in our body, mainly the head and neck movements. So next we will move to the vestibular nuclei. The nuclei has four zones. That means superior zone, middle zone, lateral zone, dorsal zones, and superior superior vestibular nuclei and inferior vestibular nuclei are mainly dealing with the utricle and macule. Inferior vestibular nuclei mainly receives afferents from the utricle and saccule and also the posterior canal. In this picture, you can able to see the two divisions of the vestibular nerve. So you can see the superior semicircular canal, inferior, medial, lateral semicircular gives fibers to the vestibular nerve, and both the divisions are able to see here that the saccule and utricle gives inferior divisions. So the vestibular nerve is there, and the cochlear nerve is adjacent to that. That from the cochlea it is arises. So the vestibular nerve has two divisions. And let us see the vestibular, then the different connections of the vestibular nuclei. From the vestibular nuclei, it connected to the oculomotor nerves, that 3, 4, 6 cranial nerves that has been connected. So first thing will be the vestibulo-ocular reflex. The vestibulo-ocular reflexes is nothing but the fastest reflex in our body, where activation of the vestibular system of the ear causes eye movement, which is to stabilize the image on the center of the retina. That means if you now I am moving my head, but instead, even though I am moving my head, I am seeing the screen. That means the eye movement are still collaborated with the head movements to maintain to stabilize the image on the center of the retina. This is a simple vestibulo-ocular reflex. It is a faster reflex in our body. Clinically, you can test this vestibulo-ocular reflex by doing the head impulse test or otherwise head tilt test. What you will have to do? You have to ask the patient to fix his eyes on your nose, and you have to tilt like this, tilt your head like this without changing her fixation on your nose. If you see any saccades or catch-ups, that means it is abnormal. If you are not seeing any catch-ups and saccades, it is normal. But in case of central nervous system disorders, the negative head impulse test indicates the brainstem pathology. That means normally vestibulo-ocular reflex would not have any nystagmus, any castor. But in case of vertigo and nystagmus, if the patient has head impulse test is negative, that indicates peripheral nervous system is normal, only the central connections are abnormal. That means the brainstem and its connections are abnormal in head impulse test become negative. So if it is negative, it is more serious in vertigo patients. Next, other reference, the same thing, vestibulo-ocular reflex, I had told you. In this picture, you can see that the head is rotated to the left. The similar way, the connections of the vestibular systems through the medial longitudinal fasciculus as connected to the oculomotor nerves, that is complex. The right sixth nerve and left third nerves are being interconnected. So that's why when the head rotates to the left, the right medial rectus and the left lateral rectus will be contracted to maintain the image on the retina. So these are the other connections. As like you can see the blue color vestibular nuclei. There are 4 nuclei are there. These are in turn connected to the spinal cord through the vestibulospinal tracts, and the cerebellum through the vestibulocerebellar tracts, and to the cortex, the vestibulocortex through the thalamus. You can able to see the upward line here to the cortex. There is no vestibular cortex, but usually the posterior parietal and the posterior temporal lobes are considered to be the parietal vestibular cortex. So in vertigo examination, our aim is to rule out the central vestibular lesions, or else we have to rule out the central cause for vertigo. That is our aim in vertigo examination. So basic neurological examination like gait testing, Ramberg testing, followed by head impulse test will be enough in diagnosing vertigo cases in clinical neurology. It means clinical OP basis. So let us go deep into the vertigo. What is vertigo and what types of vertigo, how you are going to deal in your OPD. That we are going to see now. So before going to vertigo, we must know about the terminology called dizziness. The dizziness, by definition, it is a non-specific term. It may be a faint, or it may be a woozy, or it may be a weak or unsteadiness. Any sort of feeling, the patient will come and tell you like this. So we should not miss, and we should not confuse with the dizziness with the vertigo. So dizziness is a non-specific term, whereas a vertigo, it is a subtype of dizziness. It is a hallucinatory rotatory movement of the body or the environment in the absence of true motion. Actually, it is a illusion of rotatory movements of the body or the environment. So that is vertigo. So these are this slide shows these are the vertigo mimics, or the mimics of vertigo in history. The patient comes with a vertigo, and it may be a vertigo, or it may be a syncope, it may be a disequilibrium, or it may be functional, or ataxia, or drugs induced. So we have to find out the reason for we have to find out whether it is a vertigo or some vague term described as vertigo by the patient. Sometimes patient may come with a loss of consciousness. Simply they will come and talk to you as like vertigo. So we should not miss the history. So first point is in vertigo assessment is a history. We must rule out other causes of other mimickers of vertigo like pre-syncope, like loss of consciousness, lymphatic telescoping view. These are the conditions, and cardiac issues like MI. These are has to be ruled out. And ataxia. The next thing is ataxia. Ataxia patients will say about usually say as vertigo. But if you carefully watch, they may have defect in unsteadiness while walking and impaired vision, and like that they have dysfunction, ataxia, everything they will have. And function. Sometimes the patient may have a depression or major somatization or hyperventilation as EAD, they will have associated with the functional vertigo. And sensory ataxia, as like in Rampal test, we can able to see. And other drugs like phenytoin, carbamazepine, and some benzodiazepine overdose can also cause symptoms. Sometimes hypoglycemia also leads to vertigo symptoms, but it may not be a vertigo. So the most common prevalent disease in our practice is vertigo, and we must need to differentiate peripheral from the central cause of vertigo. Before that, we must know the red flag signs in vertigo, like coronary artery disease, heart failure, arrhythmias, Galla heart disease, syncope, and brain hemorrhage. These are the red flag signs. This should be differentiated from vertigo before going to differentiate from central and peripheral vertigo. So now vertigo is two types: the vestibular or peripheral vertigo, non-vestibular or central vertigo. The vestibular vertigo or peripheral vertigo involves the vestibular apparatus, as already told, and the vestibular nerve. Whereas the central vertigo involves vestibular nuclei and the brainstem and its connections. These are the four common causes of vertigo. Like peripheral vertigo, most common cause is BPPV, Meniere's disease, viral labyrinthitis. Whereas the central cause of vertigo is migraine, stroke, multiple sclerosis, and brain tumor. These are the common causes to our practice. So this side 3 and this side 3, these are the 6 common causes of vertigo in our clinical practice. So these are the orders in the descending frequency of common presentation of vertigo symptoms. Like BPPV is the first, followed by functional dizziness and central vestibular vertigo, vestibular migraine, Meniere's disease, and acute unilateral vestibulopathy. In seasonal, it may be varied. In seasonal time, you have viral labyrinthitis is the most common cause of vertigo rather than BPPV. And sometimes paroxysmal vestibular paroxysma and functional vertigo, superior canal dehiscence, all sort of symptoms can present like this. So we must differentiate between the peripheral and central vertigo. By symptomatology, we can able to differentiate peripheral vertigo and central vertigo. But if the symptoms are more, it is more points towards the peripheral system, and usually they have associated with nausea, vomiting. The mild to moderate posterior instability will be there, and the hearing loss and tinnitus are common. They are coming mixed type of nystagmus, and duration is less than 1 minute. Whereas in the central vertigo, the symptomatology is less, where the signs are more, long track signs will be there, and the nystagmus are usually purely horizontal or purely vertical. Dorsal nystagmus also will happen in cerebral lesion, but most likely purely vertical, purely horizontal vertigo points towards the central cause. And usually they are not fixed to the eyes. That means they last longer, the more than 1 minute. By diagnosing vertigo, whether it is peripheral, central, and what type of vertigo, we are going to going to get clues from the 3 common questions, like based on the presentation, based on the triggers, and based on the duration of vertigo attacks, we can able to differentiate them into peripheral and central vertigo. So by doing presentation, if they have rotational vertigo, it may be acute vestibular disorders. If they have positional vertigo, it is BPPV, vestibular migraine, and central positional vertigo. If they have unsteadiness with no rotatory feeling, that means bilateral vestibular dysfunctions. And non-specific dysfunction, usually pre-syncope, or it may be syncogenic. Based on the triggers, if they change their head posture, that is positional vertigo, it is BPPV, and sometimes in vestibular migraine and central positional vertigo also can cause change vertigo during head posture change. During menstruation and sleep deprivation, usually vestibular migraine, and during closed space and elevators, panic attacks. Loud noise Valsalva can produce Tullio syndrome. These are the fistula symptoms. And depending upon the duration of vertigo, we can divide them into few seconds. It is usually viral. A few seconds to few minutes, it BPPV, and minutes to hour, it is TIA, and hours, it is Meniere's disease, perilymphatic fistula, migraine, or acoustic neuroma. It's days, usually Vestibular neuritis can present like in days, 2 days to 1 week. And more than weeks, it is mostly psychogenic unless no other evidence for the organic causes. So vertigo management, our management is not to simply suppress the symptoms. We should make a diagnosis and then we have to go into treat. So there are multimodal approach for the vertigo treatment. There's pharmacotherapy, physical therapy, and lifestyle changes are there. I'm going to deal only the pharmacotherapy. There are two types of drugs are available for vertigo management: vestibular suppressants and stimulants. Stimulants, only one drug available, that is beta-histidine. Vertin, everybody knows, and the followed by vestibular suppressants like Stemitil, the antiemetics like cyclizine, hyoscine, metoclopramide, these, and followed by the GABA agonist diazepam. These are vestibular suppressants and vestibular stimulants. Nootropic drugs are sometimes it will be helpful, but may not be workful in all times. So usually vestibular suppressants work by the H1 antagonism, thereby decrease the level of histamine in the brainstem, inner ear, and brain. Hence, it provides the temporary relief from the nausea and vomiting and vertigo. But usually, it should not be given for more than 3 days because it alters the central compensatory mechanism. Whereas the vestibular stimulants are H1 agonists, that will increase the histamine levels in the brainstem and vestibular nuclei, and also H3 antagonists. That means it improves the circulation in the brainstem. So by circulation H3 receptors, by histamine, it's H1 antagonist. So by doing this agonist and agonist action, vestibular stimulants can be used for longer time. But maybe 3 to 6 months it can be used. But usually according to the situation, if it is a benign postural vertigo, less than 2 weeks is enough. Acute vertigo, less than 1 week is enough. If it is a venous disease, you can use it for 3 to 6 months. Along with other maneuvers like canal repositioning maneuvers, you can use the distance. But acute vertigo, less than 1 week is enough for all sort of vertigo. If it is a long-standing vertigo or canal cupulolithiasis, canalolithiasis, or DPPV or venous disease, that time you can use it for more than 3 months. Otherwise, it is less than 1 week is enough for all sort of vertigo. So usually the vestibular suppressants are anticholinergics, antihistamines, and benzodiazepines. I already told. The problem is anticholinergic is with the blurred vision, dry mouth, constipation, tachycardia, and sleep problems. Whereas the histamines will lead to drowsiness and weight gain, and the dopa agonist will lead to tremor and antagonist will lead to tremor and dysphoria and Parkinson symptoms. Whereas the stimulant, it has no major side effects as noted by ourselves. And beta is the only non-sedating antivertigo drug. We used to recommend 72 milligram per year in a day, but we use a 16 milligram BD as a routine dose. And sometimes we may go with a 24 milligram OD, and in refractory cases, 48 milligram maximum up to 48 milligram. They are recommending TDS, but we are using 48 milligram OD is enough for the most of the cases in our practice. So vestibular, higher the dose, better the efficacy. That is a dose-dependent manner effect. By in summary, I'm going to tell it is a vertigo, whether it is a true vertigo or vertigo mimics, we have to find it out. And we must differentiate from the central vertigo from the peripheral vertigo. And basic approach to the vertigo is to rule out long track signs. That means the cerebral strains and brainstem signs should be ruled out before going to deal or before going to give beta-histidine or some Stemitil. So thank you all for the kind listening. And with this slide, I will conclude my talk. And my sincere thanks to Dr. Vikram and Dr. Rajesh sir for giving me this opportunity in IMA meet. Thank you. Thank you, sir.
Thank you, Dr. Veda sir, HOD of the Department of the Neurosurgery at the Meenakshi Super Specialty Hospital, Madurai. He did his M.Ch neurosurgery from Madras Medical College and completed in 2002. Myself and Dr. Selvamuthukumaran were together in Madras Institute of Neurology. When I joined as a postgraduate student in M.Ch in 1999, he was doing the third year M.Ch neurosurgery course. So from that time onwards, we know. So almost 25, 26 years, we know. And he has a specialization in micro and endoscopic neurosurgery. His current position is Senior Consultant and Head of the Department of Neurosurgery in the Meenakshi Vision Hospital and Research Center, Madurai. He is an expert in all aspects of neurological surgery for complete brain management, spinal cord and peripheral nerve disease and disorders. He is at present the Secretary of the prestigious Tamil Nadu Association of the Neurological Surgeons. I welcome you, Dr. Selvamuthukumaran, to give the talk on head injury. Welcome you, sir.
It is one of the most deadliest thing to occur for a human being. In India, almost 1 lakh.
Sir, your voice is a little disturbance, sir.
Hello.
Yes, sir.
Yes, sir. Now it is okay, sir.
Okay. In India, now nearly 1 lakh deaths occur every year because of RTA. And in that, most of them are due to head injury. And even among that, most of them are between the age of 20 to 40 years. It's really a pity to see young people lose their life because of head injury. So head injury management is very, very important, and the basic of which should be known to every medical person. And also for a paramedical person is going to do the initial resuscitation. The head injury management starts at the site of the accident. It doesn't start at the hospital. It should start at the site of the accident. So whenever the accident occurs, the person who is standing at the site of the accident should immediately call for help and call for ambulance. And then if he is experienced, he has to do the ABC. Nowadays, what they call is, it is a chest compression. So whenever the patient is in shock and is sinking, you have to call for help, call for the ambulance, and start the chest compression. The ratio of 30:2, and for a minute, 120 compression should be done. So 30 compressions plus 2 rescue breathing, and 100 to 120 compressions per second. This is the way to establish the breathing and the circulation. So once the airway, breathing, and circulation is established, then what you do is you have to look for the other clinical signs. So once the ambulance comes, usually high-tech ambulance, nowadays the staff nurse in the ambulance, they are experienced in intubating. So all the high-tech ambulance as a staff, emergency staff who can intubate, and all the high-tech ambulance as a good ventilator support. So at the site of the accident, ambulance will do the initial resuscitation, they can do the airway breathing circulation, they can intubate, and they can ventilate. Next slide. So one thing they should not do is, they should not paralyze the patient. So how to shift the patient from the site of the accident? This technique is known as a log roll, because they should not just lift the patient with the leg and the hand. What they should do is, they should log roll. Like a log, they should move the patient to the stretcher. There should not be movement of the spine at all. Because unless proved otherwise, any unconscious patient is supposed to have a spinal injury, and it should be ruled out with investigations. And how to shift the patient? This is the technique of straddle lift technique. See how the patient is covered within. The patient does not move the hands, legs, and this is the way to strap the patient before shifting to the hospital. Next. So in the hospital, general examination has to be done. So the scalp wounds has to be seen, and whether there is any underlying fractures has to be noted. Next. So we should look for the signs of skull base fracture, which are bilateral periorbital hematomas, also called raccoon eyes or panda bear sign, And we should look for the battle site. That is a retroauricular chemosis. These two are present. Then we should definitely rule out a head injury. Hello. Next slide. So as already told, any unconscious patient before shifting to imaging, either a CT or a MRI, it should be immobilized and then only shifted for a CT scan. Next. So what are the indications of a CT scan brain? This is a very common question. Any patient with GCS-15 with signs of skull base fracture, as already told, will need a CT brain. Or if the patient with GCS-15 with nasal bleed, with ear bleed, or non-alcoholic, or less than 2 years of age, or very old patients, or a patient with unequal people, all these patients, all the post-traumatic vomiting, or with the epilepsy, all these patients with GCS-15 needs a CT scan brain. Otherwise, less than GCS-15, whether it's GCS-14 or 13, all patients need a CT scan brain. So what is GCS? It is known as a Glasgow Coma score, where the minimum is 3 and the maximum is 15. And now there is it is known as a GCS-P, where we are, depending on the reaction of the pupils, we give some more, we reduce some points. So this is known as a Glasgow Coma scale P. Next. We have other coma scales also. Next. We have other coma scales like pediatric Glasgow coma scales, which is used for less than 1 year and more than 1 year. Next. 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 Naveen. Naveen.
Yes, sir.
Next,
It's moving, sir.
Next.
Yes,
Next.
sir,
Yes.
Yes, sir.
Another thing known as the Blantyre coma scale. Next. So once
Sir,
the
the
patient,
frequency.
yes, correct. Once the patient has been admitted, the neurological assessment should be continuous. It is not a one-time affair, because any head injury, mild head injury, will change to a moderate head injury, and moderate head injury may drop to a severe head injury. So mild head injury is GCS 13, 14, 15. Moderate is GCS 9 to 12, and GCS 8 and less than 8 is severe head injury. So patient may come as a mild head injury, but in half an hour the patient will deteriorate to a moderate head injury or may deteriorate to a severe head injury. So once a patient has a head injury, the GCS monitoring should be continuous, at least half an hour in our ICU. Usually, the initial ICU or first 2 days, there could be an half an hour GCS monitoring. So it is very, very important. Next. But see, GCS has some pitfalls, because once you intubated, the verbal response you cannot give as we have to give as VT. And sometimes when the patient is aphasic, we have to give as V1. So there will be a false low. So this will be conscious, because he is aphasic, the GCS may be low. And some they say because GCS doesn't take into pulse, respiration, BP, they cannot prognosticate with this. And again, brainstem reflexes are not included in the scale. So all these are the pitfalls of the GCS. But despite this, GCS still it is the best for the head injury observation, and it still stands a test of time. Next. Next.
Came, sir. Examination of people, sir.
So next more thing is an examination of the pupils. So when a patient with head injury comes with a unilateral dilated pupil, it is a neurosurgical emergency. Unless first we should take the patient immediately to a scan and rule out a mass lesion. So whenever there is a unilateral dilated pupil, it is a neurosurgical emergency. Most probably the patient may need a emergency surgical evacuation. But there are other causes of dilated pupil. One of the most common thing is an optic nerve injury, which causes relative apparent pupillary defect. That is, the patient will have a direct reflex absent but indirect reflex will be present. But whatever it is, anisocoria, other causes will be there, like a direct nerve injury. But these are all secondary causes. Whenever there is a dilated pupil, rule out a mass lesion, most probably they may need surgery. So don't miss a unequal pupil in a head injury patient, especially in a severe head injury patients. Next. So pupils also used for the prognosticating the head injury. So depending on the site of the injury, the patient may have different size of the pupils. In pontine issues, the pinpoint in tectal injury may be large and fixed, and in midbrain injury, it will be mid position and fixed. Next. So dorsal also is very, very important. When the dorsal movement is impaired, again the prognosis is poor. Next. So what are the other signs of a severe head injury? So Cushing's reflex. Previous slide. Previous slide. Previous slide. So Cushing's reflex. Previous. Mundra slide ponga. Previous slide ponga. Naveen, previous slide. So Cushing reflex is there is an hypertension, bradycardia, and respiratory irregularities. If these three are present, then the patient is having a raised intracranial pressure, so which needs an emergency neurosurgical management. When the patient has hypotension with bradycardia, then it is usually due to a cervical spine injury. Whenever an unconscious patient has hypotension with tachycardia, most probably it is not due to head injury. We have to rule out the abdominal, thoracic, or a long bone injury. So hypotension with tachycardia, most probably not due to head injury. Next. Traumatic brain injury, depending on the structural imaging, loss of consciousness, post-traumatic GCS. We divide into mild, moderate, and severe. Next. So what are the different types of a brain injury? One is the primary, which occurs at the site of the injury. Maybe a bony injury or a brainstem injury or a laceration or cortical injury or diffuse axonal injury. So this we cannot prevent. But what is the most important from a physician point of surgeon's point of view is prevention of the secondary brain injury due to increasing intracranial hematoma, edema, hypoxia, ischemia, and increased intracranial pressure. So our main idea of management is prevention of secondary brain injury. Next. So then we come to a focal and a diffuse injury. Focal injuries are again fractures, contusions, all the hematomas. The focal injuries, usually the prognosis is poor because as the name indicates, it is a focal injury. The most difficult to treat is the diffuse brain injury. It may be milder form as a concussion, or the most common what we see is a diffuse axonal injury. The CT scan may be a normal, but the MRI will show a lot of signal changes, and this is the diffuse cerebral injury. The prognosis is poor usually. Next. So coming to the common hematomas. This is a very common hematoma known as extradural hematoma. Usually in the CT scan, it is a classical biconvex. Usually the prognosis is poor. Prognosis is good. So once you operate, usually what we say is more than 1 centimeter with a shift or more than 30 cc volume, we operate. Usually they recover good. Next. See, this is this much of a large extradural hematoma, poor GCS. But see, on the second post-op day, the scan looks good. The patient has improved in GCS. Next. Again, this is the frontal EDH. Again, the bad severe injury GCS-6 improved immediately to GCS-14, 17th and 18th. One day, the patient has improved in GCS. All these are focal injuries. Next slide. So even a good GCS, the patient will come in good GCS, but still we have to operate these patients. And again, a very good recovery in all these patients. Next. So next thing is a subdural hematoma, where the prognosis is varied because there are associated underlying brain injury. So what we see here is the acute subdural hematoma, which is concavo-convex. It is hyperdense, or chronic is hypodense. So this is acute, subacute, and chronic. So for acute, next slide. For acute subdural hematoma, with the shift, we operate. So this patient came with a GCS of 4, but after 2 weeks, they have operated, we have removed the bone, but still the GCS has not much improved. This is because of the underlying severe brain injury. Next slide. So again, this is one of the examples. See, acute subdural, we have operated, but what we see in the post-op scan, all many infarcts and anterior circulation, posterior circulation, all infarcts are there. So prognosis will be poor, not maybe, will be poor in these patients. Next. Other thing is a post-traumatic SAH. Next. The problem in this type of SAH, because sometimes what happens is the patient will be riding a bike, the patient may have a giddiness and fall. So this may be the scan finding. This is a classical finding of an aneurysmal SAH. So when the history of trauma is not clear, and when there is an SAH like this, we should do a CT angio or a DSA throughout an aneurysm. So this is quite common. Once in a while, we get like this, we do a DSA, and there may be aneurysm. You should be very careful. Just you should take a proper history. The patient should have a definite history of RTA. Next. So this is another example of intracerebral bleed. Again, these also you should be very careful, because what happens is sometimes the patient have a giddiness and fall. This may be hypertensive bleed, or this may be a CVT bleed. So we should take a good history, because if it is a CVT or a intracerebral bleed because of hypertension, we may have to do an MRI. The treatment may change, especially if it is a CVT, as seen in the second CT brain. Next. Sometimes cortical contusion, small contusion may be there. Again, IVH may be present in a severe injury patients, which may require an external ventricular drainage. Next. So this is another thing, like by contusions. So contusions, again, the prognosis depends again on the underlying severe brain injury and the GCS. Here, this patient had a good GCS, bifrontal contusion. Whenever there is a contusion, we have to evacuate the contusion. No, nothing. We should not just remove the bone and come out. If you remove the contusion, the prognosis is poor. There is no role for the just decompressive craniotomy in these patients. Next. Next is the skull fractures. Skull fractures may be a fissure fracture. And the first scan in the left-hand corner, there are a lot of air pockets. Usually these are conservatively managed. But when there is a persistent air inside the brain, then we have to look at CSF rhinorrhea, and we may need a surgery. So other things, maybe it's a diffuse cerebral swelling or a diffuse cerebral ischemia. Sometimes delayed injury may cause hydrocephalus. These are the other findings in a CT in a head injury patients. Next. So sometimes what happens is, next, the patient is having an head injury with a normal CT brain. The milder form of which is a concussion injury, but the most severe, as already told, a diffuse axonal injury. Many a times in a diffuse axonal injury, the CT scan will look normal. The cisterns will be opened up. There will not be much findings in the CT, but we do an MRI. We find a signal changes in the gray white matter junction, dorsal in the brainstem, and in the corpus callosum. These indicates severe form of head injury. Next. And nowadays, with MRI, we do MR tractogram, which probably, still it is in research purpose, which probably may prognosticate severe head injury and recovery from head injury. But still, we have to go a long way in this tractography. Next. Next one. So, What are the recommendations of a brain trauma? Latest recommendation of brain trauma foundation. Trauma management is always, many times it is controversial in many aspects. So what are the recommendations of brain trauma foundation? Level 1 evidence is high quality, level 2 is moderate quality, 2B and 3 are low quality. Next. So the recommendations, there are many recommendations are there. Next. So recommendations are there for treatment, monitoring and thresholds. Treatment. Next. Next. So for treatment, next. So as I already told, decompressive craniotomy is done to relieve the intracranial pressure or due to cerebral edema, which may be a primary injury or secondary injury. Next. So the level of recommendation for decompressive craniotomy is level 2A. A large craniotomy should be done. There is no role for minimally invasive neurosurgery in trauma. So level of recommendation is level 2A. Next slide. So depending on the site, either we may do a frontotemporal parietal decompressive craniotomy, or if it is a bifrontal, we may do a bifrontal craniotomy. Next slide. Nowadays, what we do is we have to prevent the bone from being removed, we try to do what is known as a cystonostomy. By this, we remove the CSF from the cisterns, basal cisterns. What we call it is an optico-keratoconus. So here, what we see there is the close to section is the optic nerve. And lateral to optic nerve is the ICA. I am dissecting the arachnoid between the internal carotid artery and the optic nerve. So optico carotid. So once I am going in and I'll open another membrane known as a Lilliquist membrane to release the CSF. By this, the CSF gets released and the intracranial pressure reduces and the brain also becomes lax. So now between the intraoptic cistern, I am opening. And so releasing all the CSF. By doing this, sometimes what we can achieve is we can replace the bone flap. So to prevent the next slide home, to prevent the complications of the decompressive craniotomy. Next slide. So the other recommendations are hypothermia. Next slide, which is level 2B only. Next slide. The other main thing what we use is a hyperosmolar therapy. That is mannitol. We give it a dose of 0.25 to 1 gram per kg body weight. But mannitol used to reduce the ICP when there are signs of transtentorial herniation or when there is a progressive neurological deterioration or the scan shows a diffuse cerebral edema. Next. CSF fluid drainage recommendation is level 3 only. So the role of a EVD, that is to external ventricular drainage to drain the CSF is level 3 recommendations only. Next. Next slide. Next slide. Next. So regarding ventilation therapy, definite airway protection is needed and transient hyperventilation may be used. But the goal for nowadays, it indicates the thing is normal ventilation. And PCO2 should be maintained between 35 to 45. Next slide. There is no role for prophylactic hyperventilation. And PCO2 of 25 milligram or less is not recommended. So previously we used to say hyperventilation, but nowadays there is no role for prophylactic hyperventilation. Next. So coming to sedation. Yes, high dose barbiturate is recommended to control elevated ICP refracted to medical and surgical treatment. But it's level 2B evidence only. So propofol is nowadays not recommended. as a sedation. Next, the only one level 1 recommendation is there is no role for steroids in head injury. So don't use steroid because steroids increases the mortality rate. Next, another level 1 evidence. There is no level 1 evidence for nutrition. What in our experience, a good nutrition feeding should start as early as possible. In an unconscious patient, we try to start as even the second day, third day, we try to start, but they recommended at least we should start by the 5th day. Next. Again, early tracheostomy is needed. Definitely it is needed. And infection prophylaxis is definitely needed in all these severe head injury patients. Next. Next. So, what is the role of a deep vein thrombosis prophylaxis? They say it is a level 3 evidence, that is, low molecular heparin should be used. But what in our practice we have seen that SCD, that is sequential compression device, should be all used in all patients with severe head injury. All unconscious patients usually do SCD, and usually in our institute, what we follow is prophylactic low molecular heparin in the first week itself. So after 7 days, we do a scan. If there is no fresh bleed, we start low molecular heparin. Definitely, we found to be very useful. Though the Brain Trauma Foundation say it is a level 3 evidence only. Next. So seizure is one of the most difficult thing to manage. There may be a post-traumatic seizure, which is classified into early and late, or post-traumatic epilepsy, which is defined as a recurrent seizures more than 7 days following head injury. Next. Again, when to start seizure prophylaxis, it is very, very difficult to answer. But some risk factors they identify like GCS less than 10, immediate seizure, post-traumatic amnesia lasting for more than 30 minutes, depressed skull fracture, penetrating head injury, intracerebral edema, age less than 65, chronic alcoholism. All these, they are risk factor for seizure. Next. So seizure prophylaxis, what we do is we give for all the severe brain injury patients and patients with intracerebral hematoma and cortical contusions. Next. So recommendations, seizure recommendation is a level 2 evidence. So now, next. Now coming to monitoring. So what are the monitoring? ICP monitoring is there, cerebral perfusion monitoring is there, advanced monitoring like brain tissue oximeter, ECG, transcranial Doppler, and JVO2 is there. But all these, there is advanced cerebral monitoring and cerebral perfusion monitoring are not commonly used, not used in our institute. What we use is an intracranial pressure monitoring. Next. So the main idea in head injury management is maintain the cerebral perfusion pressure, which is nothing but the mean arterial pressure minus the ICP. So maintain the cerebral CPP around 80 to 90 millimeters is the treatment standard of care. Next. So what we do by using ICP monitor is video play pannunga, make it just a small burrow. Just make a small incision. All these are done at the bedside. Just we'll keep an ICP catheter, and which causes by which we continuously monitor the intracranial pressure. So see, so this is the Codman's ICP pressure we use. Usually we try to maintain the pressure of less than 20. See, so the monitors will come here in this. See, okay. Next, ponga. Next slide. See, the ICP is 17. Next. So some of the indications of ICP monitor. This is a classical. Next slide. See, this patient has a severe edema. See, the systems are not visualized, but there is no mass lesion as such to operate. No contusion or subdural extradural. What these do is we do an ICP monitor for this patient. And definitely, it is very, very helpful. Depending on the ICP monitor, We plan the number of days of sedation, number of days of ventilator, everything we decide. And definitely this is very, very useful from my experience, because there is controversy, lot of controversies are there, but we usually do an ICP monitoring. Next. But according to the Brain Trauma Foundation, this is level 2B evidence. Next. அடுத்த 4 slide skip பண்ணிருங்க. Next போங்க. So all these are not followed regularly, so I am skipping these. Next. So all these recommendation also is not there from the Brain Trauma Foundation. Next. So the final thing is you have to maintain the next போங்க. Next பேருங்க. Next. போங்க. Cut பண்ணலாம். Okay. So the neurosurgery has evolved very rapidly for the past 4 or 5 decades. What the surgery we done 15 years back, now we are not doing now. The techniques, everything has changed much in the last 15 years. So with experience of 22 years, what I did surgery during my postgraduate and what I did during my elective neurosurgery, what I did during 2005, now it is completely different. The technique which we use, the microscope which we use, the intraoperative monitoring, endoscope assisted, so much has changed in elective neurosurgery in the past decades and is still rapidly changing every year. But it is not the same with head injury. Probably because of the ventilator, because of the rehabilitation, probably the morbidity is slightly better. Probably the mortality is better, but the morbidity is still there. Still, treatment has not much changed. So researchers are trying to find the biomarkers to predict. Still, I cannot, when a patient presents with GCS-4 or 5, still I cannot predict whether this patient will improve or will not improve. I cannot predict. So the researchers are coming with various biomarkers like GFAP, SDP150, tau proteins, p-tau proteins, t-tau proteins, auto S100B. So many things they are coming up, but still all these are in research purpose. Next. So what is the role of these biomarkers? To evaluate the patient's scores and effects of treatment for all patients. And if these biomarkers are present, you can think of a new potential therapy so that improve the prognosis of these patients. Next. So any disease, we come to stem cell therapy. Here also, stem cell therapy is there, but still under trial, and at present, no recommendations. Next period. Next. So finally, what to do? So barbiturates as prophylaxis is not recommended, but iodose probate is recommended to control refractory elevated ICP. Propofol is not recommended for improvement in mortality at 6 months outcome. Prophylactic hyperventilation is not recommended. Next. ICP monitoring should be monitored. It is definitely useful, and cerebral perfusion pressure is to be maintained. Next. So systemic blood pressure should be more than 100 millimeters of mercury for 50 to 69 and 110 millimeters of mercury for patients between 15 to 14 years. ICP more than 22 should be treated. CPP should be maintained between 60 to 70 mm of mercury. Next. So why I put this slide? Probably he is the first person to have a transplant. So till now, a transplant or brain transplant, whatever it is still not there. All organs are transplanted, but there is no yet transplant. So as I already told, still the management of head injury has not much changed. The prognosis has not much changed. That's definitely changes there, but not much changed. Next, so the prevention is better than cure. Always please wear an helmet. You, when you go out, wear a helmet. Whenever you see a patient or your relative, ask them to wear a helmet to prevent an head injury. Next slide. Thank you for a patient listening, and this is our team. Thank you.
Yes, sir.
So it is an exhaustive lecture from Dr. Selvamuthukumaran and Dr. It's a very nice. Thank you for your nice lectures. Thank you one and all. We will meet once again in next month.